Good afternoon, everyone. And good morning, depending on where you're tuning in from. Thank you for joining this satellite session called Pandemic Proofing Primary Healthcare. My name is Dr. Nantalina Mugala. I'm the Chief of Africa Region at PATH. For those of you who may not be familiar with PATH, we are a global nonprofit organization dedicated to health equity with more than 40 years of experience forging multi-sector partnerships and with expertise in science, economics, technology, advocacy, and dozens of other specialties. PATH develops and scales up innovative solutions to the world's most pressing health challenges. Our goal for today's session is simple. This month, we reflect on the one-year anniversary of the World Health Organization declaring COVID-19 a global pandemic. What better time than now and at this conference to take a deeper look at health systems across the African region and share learnings with one another about what has worked or hasn't worked as we endeavor to build strong and resilient health systems that meet the needs of those who bear the greatest burden of disease and face other forms of social inequity. I'm looking forward to hearing from our panel of experts in community advocacy, health system strengthening, and digital health solutions, as well as from all you tuning in as we explore this relevant and important topic. I can see from our participant list that we have true health systems experts participating today, from governments, community organizations, NGOs, donors, and the private sector partners. We very much want to hear from you during this conversation, so please share your questions and comments with us by submitting them in the chat or Q&A box at any point during the webinar. We will have some time in the latter half of this hour for the audience Q&A. To frame the discussion, the COVID-19 pandemic has deeply reinforced the importance of integrated, people-centered primary health care, now more than ever. Our conversation today will explore lessons learned during the COVID pandemic to inform post-pandemic health systems. What are the most impactful interventions we've seen during the pandemic? And how will these advances safeguard us against a future pandemic or other emerging health threat? Before we jump into a facilitated discussion, I want to share a few data points as background. As we all know, COVID-19 has had a catastrophic impact on health systems and access to care, but the impact has varied significantly across countries and health areas. I'd like to start by sharing an analysis that my team at PATH conducted with support from the Gates Foundation. What we did is that we compared essential health services that are part of the primary healthcare systems in 5 countries, comparing data, and you can see the 5 countries there, comparing data from quarter 1 of 2019 and quarter 3 of 2019 and quarter 3 of 2020, as reported by UNICEF. From 2019, pre-pandemic, the disruptions stand out very, very plainly. And you can see that from this slide. And though they vary by country, they tended to be most significant for immunization and sick child care services across locations. And that's very, very evident from that analysis in the slide that you see. Looking at another set of data that was collected and provided by the Global Fund and their partner health ministries, we have evidence of disruption in HIV, TB, and malaria control and prevention as well. Though you can see and appreciate some recovery in sight, 3/4 of the countries that were being tracked are still experiencing disruptions in HIV and TB services, and more than half in malaria service delivery. As the pandemic took off in early 2020, the early innovations to adapt primary care services and maintain access were astounding in their depth and breadth. We catalog here some of the most common actions taken to improve safety and infection prevention control at health facilities, as well as a suite of options to enable remote healthcare through virtual engagement, telehealth, through home visits or task shifting, and simplifying health services through multi-month scripting, service bundling, self-care, just to mention a few. So really great innovations. So while the challenges are real, we also have brilliant examples of how we can think outside of traditional models. And many of these changes aren't just better in these pandemic times, but could actually make the way we deliver services and care more equitable and accessible going forward. This does require concerted effort from all stakeholders. So with that context, ladies and gentlemen, I am excited to hand the conversation over to my colleague, Dr. Kimberly Green, Director of Primary Health Care here at PATH, who will introduce our panel of experts and kick off our discussion. Dr. Green, it's over to you. Thank you very much.
Thank you, Dr. Mugala, for that excellent framing of primary healthcare and primary healthcare really at the front lines of the COVID-19 response and what we can learn from adaptations and some of the innovations in ensuring access to essential health services as we build back. So with that, I would like to introduce our esteemed panelists who have joined us today. First, starting with Dr. Siobhan Bienmukama. She's the Managing Director at Babel Health in Rwanda and has implemented some leading edge telemedicine efforts across Rwanda, and you'll hear more about those in a moment. Next, I'd like to introduce Dr. Salim Hussein, who's the head of primary healthcare division at the Ministry of Health in Kenya. He's equally a great champion for primary healthcare and the role of community engagement, and look forward to hearing more of his perspective about how Kenya has responded to COVID-19 at the primary care level. We'll then hear from Carol Nawina Kachenga, who's the Executive Director of CTAM Plus in Zambia, and many of you may know of her. She is a globally known advocate for better healthcare for people living with HIV, people with TB, and other populations in need of healthcare services in Zambia. And then last, I'd like to introduce Dr. Yeko Yesu Worku. He is currently the team leader for the Office of Health System Strengthening and Resilience at USAID in Ethiopia. But he's going to be talking to us today primarily from his very recent experience over the last 3 years working at the Ethiopian Ministry of Health as the Director General for Health Systems and Operations and also Chief of Staff for the Minister's Office. So all of our speakers' bios are available as part of the session program, and I encourage you to read more about them and their stellar expertise. So now I would like to transition to the Q&A with the panelists. And I'd like to start first with you, Carol. So you are a longstanding advocate for healthcare for all. And you've worked in the community level at the national level. You're also a person living with HIV and a person who has had TB. So I'd like to ask your impressions about what you've seen in terms of how COVID-19 has impacted access to essential health services in Zambia, including the people that you serve through CTAM Plus. Over to you. Carol, you're on mute.
Yes, thank you, Dr. Green. Sorry about that. Primary health care, as we are told, is a whole of society approach to health and well-being centered on meeting the health needs and preferences of individuals, families, and communities throughout their lives, with some of the principles being accessibility and public participation. We do understand and appreciate that governments have to be in the forefront when there is a public health emergency. At this point, we're talking about COVID-19. But then they should also not leave anyone behind and ensure that they are empowering individuals, families, and communities to also take charge of their own health. We've noticed that in the case of COVID, it's more, government oriented and people being told what to do and where to go. For me, what I've seen is the way COVID-19 has been portrayed, even now, is still like a death sentence, first and foremost. You are not really given initially the chance of survival. It reminds me of the early days of, actually, I won't even say HIV, but of AIDS. It's like once your diagnosis was positive, you were, given a death sentence. And because of this, we've seen a lot of suicidal tendencies after people receive a positive COVID result, and especially if maybe one of their colleagues, if it's at work, one of their colleagues passes on, we've seen that people are really, getting suicidal. And unfortunately, this has increased all forms of stigma. For me, I feel that all the investment that we put in, for us who worked in stigma reduction in the days of HIV, has sort of gone to waste, because we are seeing an increase in stigma in the terms of COVID-19. So we really need to encourage a people-centered approach in order to keep creating demand and ensure that people can and continue to access health services. So what I've seen here in Zambia, just come back to Zambia, is that COVID-19 has negatively influenced health-seeking behavior. Because people were told you cannot go to the health facility, or if you go to the health facility, that's where you find COVID. So it put fear into a lot of people. People stopped going to hospitals because they're afraid of that. But also sometimes being told that if you have these signs and symptoms, if you go to the facility, you might not be as taken care of. And the other reason is that we noticed that, like it was when we started doing our TB work, was that COVID-19 is very medicalized. So people don't fully understand what it is. They don't understand the pattern of the virus and the disease itself, to the point where you find that sometimes healthcare providers don't want to take care of someone. If you go there coughing and sneezing and a few symptoms of COVID, you are turned away. And as we know, the difference between TB and TB and COVID is very minimal. So you could go there with them thinking what you have is COVID, but what you have is TB. So you're turned away, and you go home and you keep infecting your family or your neighbors, and especially for the under 5 who are more vulnerable, as well as people with compromised immunity. So there's that issue where you're turned away. So there's that fear that has been put in people because of COVID, instead of really being told exactly how to take care of themselves. The other thing that I noticed is the issue of most of the resources being taken away from COVID. In TB, you find that most of the gene expert machines have gone to doing the COVID work. So most of the resources have been moved from other health services and taken away, instead of putting everything together, to integrate the general case management. So a lot of that has gone there, as well as the health facility. So when it comes to TB, that is even making it worse. We also tried trying to congest the health facility, came up with a DSD, the differentiated service delivery model, where patients can collect 3 to 6 months drugs without supervision between. But then what you notice that it has come back with their own issues, because some people stop taking their medication in between. HIV people stop taking their medication, TB people stop in the middle, and it's supposed to help decongest, but it has also come up with its own issues. Coming back again to COVID, we teach people, social distancing, wear your mask, use sanitizer. You're talking to my grandmother at the village. She doesn't have money to buy any of these enablers, the mask and the sanitizers. And that really doesn't help. So I wanted to sort of just get an excerpt from the Alma Ata Declaration, where it says, the people have a right and duty to participate individually and collectively in the planning and implementation of their healthcare. This is what helped make history in the era of HIV. Everybody says HIV worked very well. As people living with HIV, we're given an opportunity to really take ownership in our illness at all levels. And then the information and the behavior pattern of the virus, the disease itself, the HIV cycle was so simplified to the point where you didn't need to go to a hospital for a doctor to tell you should take your medication on time and this is what would happen. So if that would happen, that would also be helpful. So if we don't have a people-centered approach, we will not attain universal health coverage, and especially if we continue pitting one disease against the other.
Yes, thank you. So yeah, clearly there's, as you framed, there's so much to learn from HIV in the early days in HIV, and thinking about stigma and how to transfer the learning from HIV and TB to a stigma around COVID-19. And it sounds like there's still a lot of work that has to be done there. And so one of those, as you talked about, the key role of primary healthcare is ensuring it's accessible. And if stigma is not addressed, then that's a fundamental barrier to access. And you also talked about how fear of coming into health services has caused people not to come in. So that's inhibited access. While at the same time, there's confusion between whether someone might have TB or COVID-19 and who are still not getting the care that they need. And also, interestingly, you talked about differentiated models and how they work in some ways because they're decongesting the health facilities, but maybe they're not always people-centered, and how to balance that. So you've already provided a lot of, I think, solutions or ideas for the way forward. But I think, my follow-up question to you would be, as you're looking forward now, as countries are building back, vaccine coverage is pushed out, and we're looking at returning to primary health care that's comprehensive and integrative. What would you like to see in place? Is there anything different from how things were done before that you'd like to see in place?
Okay, just a quick one. I think I'll just go back to say they go to universal health coverage to ensure that all people obtain the health services they need without suffering financial hardship when they're paying for them. So like I said, it's really, as we are teaching people, as we are telling them what to do, we should be able to support them with, if we're talking about masks or hand sanitizers and whatever, we should walk the talk. And then also, like I said, we should, whether we like it or not, it has to be people-centered. I read somewhere where in West Africa, in the times of Ebola, there's a community that's, things work really well. And when people went to investigate, they found that they had given ownership to the community. In as much as Ebola was also a public health problem, they gave the ownership to the community, and the community came up with their own, ways and means that were tailored to suit them. So for me, if that happens, that will also work very well. But also the health education, it is really, really important to not just say this is a doctor's illness, it's COVID, you don't know about it. Make people understand why should they be correct. And also the last one is the recognition and the role of all partners. Because if you say you are patients, you can't take part in this, and that becomes a problem. So as we are working, recognizing everybody, bringing everybody around the table and working as a collective, I believe if we make those changes, then it's going to work. But if we put in that separation, we'll still.
Thank you. Thanks, Carol, and apologies. I just lost connection there for a moment. So clearly the message is walk the talk for primary healthcare. It's got to be people-centered. Community solutions are essential, and the financing to ensure that people can really access the care they need. So with that, I would like to turn to Dr. Salim Hussain. So Salim, you have been such a significant champion of community engagement with primary healthcare. How would you respond to what Carol's talked about in terms of the situation in Zambia? And what lessons have you learned in Kenya that you think would be transferable to other country healthcare systems in terms of relationships with the community and building trust? Over to you.
Thank you very much, Kathleen, for inviting me to be part of this to share the Kenyan experience. I'm very grateful for what Carol has started saying, and it is very important that we do not overlook other diseases because of others, especially what happened with COVID. And our example is very typical, TB, where the symptoms could be very similar. But I think what we learned in Kenya, especially with COVID, is that the PHC is very important and very integral. And as we are working towards getting to UHC using PHC, one of the lessons we learned in our pilot is that going the curative or being very curative oriented actually does not help. Actually, it made things worse for us. In our facilities, we ended up having about 200% increase in patients attendance instead of reduction. So one of the lessons we learned is that it's very important for us to be preventive, promotive, and have a PHC on the forefront. The other thing in terms of using technology, I think it came very clearly for us in Kenya that it can be a double sword, edged sword, that it can either help or it can actually be one of the challenges that you can face. For us, it really helped us in terms of getting to our community health volunteers because we had the data, but we also, it was the same social media that was actually sending a lot of myth and misinformation from the social media. So we had to deal with that. But in terms of technology, it really helped us this time of COVID. We have managed to train over 95 community volunteers using actually technology. We brought them on board. We have managed to have more access to services because of using technology. Currently, in some of the areas, we started the piloting for UHC. There are 100% digital based instead of the former paper-based tool that we used in the community-based health information. So we can see that one of the major things that COVID showed us is that PH is integral. The lip service that we have been giving it, we need to change. We need to give it the urgency and the importance that it deserves, and also look at the whole building block so that PHC actually can be looked as a complementary, not as a by the way or an approach that can only be brought when there are challenges. So I think for me, those are some of the things that we really learned and think we should pick and say that PHC is a part of the system. Health system strengthening should be based on a PHC and community based, and the people need to be engaged. Thank you. Over.
Thank you. That's excellent. So yes, from what you said, primary healthcare this pandemic has showed us it's integral. We need to invest in primary healthcare, and also because of the preventative care that you can seek through primary healthcare. And so related to that, just thinking about, COVID-19 has caught the world by surprise, and we'll be dealing with it for a long time yet to come. But there will be other pandemics. So from your perspective, what do you think is essential for Kenya in ensuring that primary healthcare is equipped to be at the front lines of identifying and responding to current pandemics, but also future pandemics? Over to you.
Okay, thank you very much. I think some of the important things for me, one is institutionalization of primary healthcare so that it is not there by chance. So one of the things we are doing in the country, we are actually developing the primary healthcare documents. We have already developed the Kenya Community Health Policy has a document. We are actually currently, as we are speaking, from one of the counties, we are disseminating the same. And also having legal framework that are actually supporting the same. For example, for us in the community health space, we are actually coming up with community health services bills and act so that the implementation of community health services in Kenya is actually under a legal mandate. The payment of the stipend is actually under a legal mandate, so it is not by just the whim of the government the government that is there during that time. So all these are anchored under documentation and legal mandate. The other thing, it's very important for us to have ownership from all the stakeholders, not just in the health sector, but also in the non-health sectors. So we have seen that COVID actually meant that all the sectors come together. It is not just about the Ministry of Health, the Ministry of Water, the issues to do with sanitation, Ministry of Environment are very important. So we are actually also now coming up with the documents, with the policies and the guidelines on intersectoral and multisectoral collaboration and actually implementing the health in all policies approach. And I think lastly, it has taught us that we need actually to be prepared in terms of all the building blocks so that we can be prepared. And where we have gaps, for example, in terms of human resource for health, we're actually coming up with what one of the reorientation in our primary health care is what we are calling the multidisciplinary team, which will be working in the primary health care networks so that we actually work as a team. We have synergy despite the fact that we have a human resource shortage. Thank you. Over.
That's really exciting to hear. So it sounds like there's a real investment in a multi-sectoral approach and in a multidisciplinary team at the primary healthcare level, and that you're setting up systems to finance that system. And yeah, I mean, I think that's really exciting in terms of where we need to head to so that primary healthcare systems can respond to current and future pandemics. So thank you very much for that. I would now like to turn to Dr. Siobhan. So, Siobhan, Babel is an excellent example of a public-private partnership that was way ahead of the curve in terms of telemedicine, and of course, way ahead of the COVID-19 pandemic. So can you talk about what were some of the initial barriers that you kind of confronted before COVID-19 and setting up your business in telemedicine that then enabled you to roll out this service in Rwanda? And what are the keys to success in building a partnership with the government for telemedicine? Over to you.
Thank you very much. So Babel is part of a global company called Babylon, and we provide digital health over the telephone. We believe that healthcare could be complicated. I mean, sickness could be complicated, but getting medication and getting well shouldn't be complicated. So our vision is to provide accessible and affordable healthcare to everyone on earth using the smartphones that people have. So when we came to Rwanda, what are the phones that people have? There was only 10, we started our operations in Rwanda in 2016, and there was only 10% smartphone penetration. So the phones that were in people's hands were actually feature phones, and yet our product was sort of smartphone built. That was challenge number one. The way we operate is a smartphone built, and we have doctors and nurses and everybody in the UK and all our destinations working from home. Would every doctor and nurse in Rwanda that we employ have internet access, have a laptop, have all this equipment? And so these were some of the initial challenges. And what we did is sort of adapt our product because we want to be able to use people's phones that people already have in their phones to provide the care that we need. So we actually changed the way our platform was interfaced. Our product can now be used on any phone, regardless of whether it's a smartphone or feature phone. We have a call center that has over 100 doctors, 137 nurses that provide the care in a call center, because it was a place where you're then sure that everybody has a laptop, everybody has internet access. We can monitor the quality of the services that we provide, and people can use the feature phone that they have. So they just dial a short code. We call them and do a consultation with them. Very easy to give them a code for them to go to the next, to get their prescriptions or laboratory tests. So that was one of the challenges that we faced. The other challenge is obviously it was a new product. People were used to accessing care in a particular way. So, how is it possible that you can treat me without actually touching me? So I think that what happened is we just said, let us get going. Let people see what we do. And there were so many beautiful stories of people calling in from a market somewhere, speaking to a doctor from wherever you are. And so over a period of time, we got a lot of traction. For now, we have about 2.4 million people registered that on our platform. We have our operation everywhere in the country. And we are in over 490 health centers out of 506 health centers throughout the country. We do about 3,500 consultations every day. But this is coming from a place where people were very skeptical. And I think it's to just have the zeal and the tenacity to keep going and just show what your product is. So that was the other challenge. The other challenge that we faced is obviously when you're negotiating with government, sometimes, who is government? Is it the Ministry of Health that is giving me the license? Is it the payer is that the government? Is it the health center place that I'm going to send off my people to go and do the laboratory tests and prescription? Is it the Ministry of Health, Ministry of ICT? So who is my stakeholder? Who is my primary stakeholder? And sometimes navigating through all these different stakeholders can be really challenging. And so So those are some of the challenges that we faced. In terms of keys to success, one of the key to success, I think, specifically for Rwanda, is that Rwanda has positioned itself as a proof of concept country. Come, prove your concepts, see how it goes, and then go elsewhere. So they've created the relevant working environment and collaboration with people who are innovative to sort of work with them. The other challenge that, the other key to success is the ability to have universal healthcare in Rwanda. I remember that when we said, let us just try a service, we actually started giving out the service for free so that people can experience our service, so that, you know, people get used to the service. And then we went into a challenge where people, we provide the service for free, and the person needed to go and get a laboratory test and quickly realizes, oh, am I paying out of pocket? Is my insurance not going to work if, you know, if I'm not, am I going to pay my own medication? So it became really, really complex. And so that is a challenge that we faced. And so one of the things that we really had to do is to say, how are we able to get people to use the universal healthcare service? And with technology, we're trying to provide a service at a cheaper cost, but it's an entire ecosystem. So even if you're saying, I am going to charge $1 per consultation, what is the cost of the laboratory test? What is the cost of the prescription? So that sort of, it has to be an entire ecosystem. The other area, I think that a key to success for us was the existing operating environment. We are in all the 30 districts. As I said, we're in 491 out of 506 health centers. To be able to access our services and get a prescription and go and get your prescription code redeemed, you should be able to, apologies, you should be able to get your prescription redeemed, you should be able to have internet access. It has to be on a laptop. Are these things in place to be able to get you to that success level? So I think those are some of the stories I wanted to share.
Thank you. That's great. And thank you very much for sharing. You addressed, I think, one of the main challenges we all think about, which is, you know, coverage of and types of phones that people have and access to Wi-Fi, as well as the financing piece. So, you know, with that, I'd love to hear your perspective on, you know, moving forward with remote, you know, medicine options like the ones that you've set up, and really thinking about them as being part of the future of primary healthcare. And so how did COVID affect your strategy? And were there more people coming to you with questions around how they could do what you've done in Rwanda and other places? And just in general, what would your advice be? You said Rwanda is a place for innovation and as an incubator. And if it works in Rwanda, then looking at how to adapt and translate it to other settings. So what would your advice be to others that are interested in adapting what you've done?
So for starters, I think that I would say that we were COVID ready. I think that what COVID did for us was to sort of validate what our vision was. We always believed that people can use the mobile phones that they have to access healthcare. So with the pandemic, that was almost like validating what our vision was. There was a lot of lockdown. People wouldn't, you know, move. And we always believed that, you know, you don't have to clog the healthcare system, you know? Why don't we deal with conditions that can be dealt with on the mobile phones and leave the healthcare system to deal with the critically ill? So I feel like the COVID was almost like a validation process of the things that we were kind of thinking through over a period of time. And indeed, during the COVID period, especially during the lockdown, we saw the number of consultations that we're doing significantly go up. We saw that we were about 155% of our patients increased because of the lockdown, and people could easily access our healthcare services. But because we're already embedded in the healthcare system, we're already everywhere in the country, we were able to support sort of like decongest health facilities, and that was a major contribution. Starting in November, we played a more direct role. All the patients in Kigali that were COVID positive, if they were asymptomatic or mildly symptomatic, we were taking care of them. Kigali is sort of like the epicenter where the majority of cases of COVID are. So we would call you every day and proactively look after you and then refer you to a health facility or to the next level if we think that you're very critical. And then what that prevents is that not everybody, because I've tested positive or because I have a slight cough, I'm going to the health facility to clog the system. So I feel like indeed, for me, what COVID did was sort of like validate that work that we have been doing. And what more can we do in the healthcare space? Now we're talking about telemedicine. How about AI? What is the role that AI can play in the healthcare space? I think that there's not a lot of innovation that has taken place in the healthcare space. And I think that we have to think through things like use of AI in providing healthcare, which is part of our next phase as Babylon. In terms of advice, or in terms of what would I tell governments, a couple of things. I mean, governments, different stakeholders. One of the things is create an enabling environment for innovators and attract them to your countries, because there are so many countries that people are going, the innovators are going to go to. Make your country, make Africa an attractive place for investors to come in and innovate, especially in the healthcare space, where we know that the 50% of the world population doesn't have access to healthcare, and unfortunately, Africa is a continent in which we are not doing amazing in terms of the healthcare space. So let us allow for a lot of these innovations to take place on our continent. The second thing is that it can be confusing for an innovator or an investor to come into a country and looking at multi-stakeholders. So who is my stakeholder? I think I talked about this a bit earlier. Is it the payer? Is it the person giving me the license? Is it, I'm an investor, is it the person who is taking care of investors? Who is my stakeholder? How do I navigate this process? And I think that if there was an easy way, and I think that we learned through the process that this is what we should have done from the start, is there a convener of all these different stakeholders? Is there an opportunity for me to negotiate with all these stakeholders so that when I'm talking to because they have competing interests, the Ministry of Health will be wanting to make sure, are you taking care of my patients and the population? The payer is trying to get how are you going to do that at the lowest cost possible? Minister of ICT, will be looking at the innovation that you bring. So there are different interests and people are looking at different. How do you convene all these people to make it easier for the investor to come and speak to government, and government is an umbrella of different people or different interests or different organizations, so that it's one voice that you're having a conversation with. The other thing that was really relevant for us is and I think that on the table of all governments in Africa, is the importance of universal healthcare. Because you're going to have innovators that are going to come in to provide healthcare at a much cheaper price, but it's an entire ecosystem. So as I said, if I provide healthcare at $1, and it's $20 to go and just do a laboratory test, and it's $30 to get the medication I need, you can't innovate in one part without innovating in the other. And also you can't take care of a cost in one area and not everywhere else. So I feel like people need to have insurance to be able to allow them to be able to access healthcare more holistically.
Excellent, thank you. Yes, I mean, I think it's a wonderful call to action to invite more entrepreneurs, more innovators to bring forward their ideas around how to make healthcare more accessible, including telemedicine and AI. So thank you, it's really inspiring. So with that, I would like to turn to Dr. Yeko. So you wear two hats. You are formerly working with the Ministry of Health in Ethiopia and now with USAID on health systems. So from two vantage points, what would you see in terms of Ethiopia's health system and how it's the primary healthcare system has responded to COVID-19 and how resilient it's been. Over to you.
Thank you so much, Dr. Kimberly, and thank you for inviting me to this interesting session. And I like to appreciate, the previous speakers for, bringing lots of issues. So, health systems is cross-cutting. There are building blocks that have been the focus of Ministry of Health of every country and also donors. And from time to time, investing in program specific systems issue is not a preferred way, rather a cross-cutting health system building and making it resilient is now the new fashion. So when we say resilient, there are three important terms that we use, which will advise the resilience of our health systems. The first one is mitigating any shock, any emergency, early detection, and providing quick feedback. So that is like a mitigation which needs an absorptive capacity. So we need to ask our system whether it can do that or not. The second one is adapting to. Once we learn lessons from what has been invested, what has worked well and what didn't work well, we need to be able to have a system that is adaptable to run. And the third one is recover and then transform permanently for future shocks. So these are like the three steps. And I think COVID has taught us its lesson and how vulnerable our health system is in terms of these three stages. So building a health system, a resilient health system, needs absorptive capacity, how to detect, respond, and the second one is how to adaptive capacity, how to adapt, and also how to transform. So taking this into consideration, COVID was initially reported sometime in January, February, then the first case detected in Ethiopia in March. So we had that opportunity to really utilize the first phase as preparedness. So, activating the public health emergency management system. This is not just like a switch on, switch off, kind of button. So it needed, the whole awakening moment. And there was one institution working on it, Ethiopian Public Health Institute, which is a little bit far away from Ministry of Health. So one key lesson we learned is emergency response has to be not only health sector, but multi-sectoral response. And the second thing that we did was immediate national task force establishment. So public health emergency experts are there, but other services on primary health care, including resource mobilizers, including quality of care professionals, including vaccine and pharmaceuticals. All this has to be established. So we don't deal with public health emergencies in only public health institutions. We need to have cumulative. And one important role that private sector played in here was professional associations. So we need to engage them in the response to contribute their own part. And the third one is spending time to analyze our capacity, how to respond to this, how to build our absorptive capacity, human resource capacity assessment, health workforce mapping, not only those who are in the market, but also in the training institution, as well as who retired. So we need to have that database, and we did to come up within a short period of time to know how much do we have. At the same time, medical drugs, equipments, where are they? Which hospitals, which facility? That mapping really helped us to mitigate the sooner possible. The other part is resource, because we are not, our system in general, in fact, the global countries' health system was not prepared for such a pandemic with such a magnitude. So, all resources were dedicated, were fractionated. Now we have to think which one to reprogram, which one to drop, and which one to utilize. And I think I would like to emphasize here is COVID was an opportunity for government to wake up and see how much they should invest in the health sector, and partners, development partners also played their major role in ensuring that. And for the future, we need to have its own emergency pool fund, because further epidemics might also come in. And the other important component was the regular engagement. So there was a false information coming out of the other end, but we need to come up with regular engagement with all stakeholders, including private sector, civil society organization, and also supporting partners. One thing I would like to really emphasize on this one is the role of private sector. So what we have learned is previously, there was no trust between private sector and the government. Government always assumed private sector is for profit. And in private sector always, not always, but most of the time accuse government that we are very much protective of our health system. We don't share, we don't open up, as Dr. Shivon was also mentioning part of it. So that trust, there is no time during COVID. We need to come up, we need to plan together. And one thing that we have learned and we open up was allowing more private sector to come into the COVID prevention and care and treatment sector. And I have seen, hotels which were closed during COVID pandemic come to an import business where personal protective equipments and other important commodities, imported obviously. And our regulatory system was so flexible enough to record from 300 to 450 new importers on health commodities. So that's how we were adapting the first phase of it. And the second one, responding the first, the shock one. The second one is we woke up and we said all our essential non-COVID services really dramatically reduced. Why? Because we have acted aggressively, as Carol was mentioning. There was stigma, discrimination. Health professionals were so frightened and less confident. So what should we do? Building that capacity, correcting the communication through media and all social media as well as cable media. And three, we need to come up with a strategy specifically how to provide essential services and maintain them in the time of COVID. So instead of dividing facilities, COVID service providing facility and then COVID, then we learn how to hybrid a facility, create a model, how to serve COVID patients. And one of the critical challenge was access to commodities, personal protective equipment for health professionals. That was a challenge because we wake up very late for procurement, and the global crisis really hindered us to really get into the market. So what did we do? We explored all our storage, private, NGOs, partners, and come back to that. And then that means our procurement system has to be so much flexible. It was not ready, very lengthy procurement process. Then it was an emergency decision to be flexible, grab what we have, and serve the non-COVID primary health care services. So these were some of high-level lessons learned, what helped us to really respond better. But we are seeing an increment starting from past month. As I was talking before the session with Dr. Natalile, that we are still investigating and then learning what is the new peak. And maybe January, February social gatherings in Ethiopia contributed to that. But still, it's a learning, adapting, and responding, moment.
Thank you. Thank you. That's great. And I love your framing about mitigating shock, adaptation, recover, and transform. And so we're at a point right now where we've received a couple of really good questions from the audience. And I would like to pose one of these questions, which focuses really on examples of integration within primary healthcare and sort of how how integration is really happening. And also, I think it would be interesting to add in the telemedicine piece as well, and how integration may be enabled or not by telemedicine as a feature for primary healthcare. So I'd like to turn this question over to the panelists and see if anyone would like to jump in first with a response.
I would like to jump in first. In terms of to be able to integrate with the healthcare system, I think that a lot of that has to be with, I think the last panelist was talking about trust and partnerships. A lot of these things are going to be very innovative. What is the appetite and willingness of people to sort of like try, learn together, and just do? So, and giving Babo's example, one of the things that we did is we had a year's trial to then say, okay, this is what it is that we're looking to do. These are the KPIs, this is what we need to deliver. And then we sit down and say, okay, what does success look like? And we went through that trial and learned from it, both parties learned from it and said, okay, how do we take this forward to a long-term partnerships? So right now, given after that, and we went through a lengthy negotiation process, we then, and there was willingness on both sides. So if during the trial process, we had access to all the health facilities so that, you know, someone who is accessing our healthcare can actually go to, because we want you to experience healthcare that like you would in a physical facility. So the insurer was saying that, okay, I will pay for the medication and prescription and so on. And so what it is that we did essentially was let us learn and move on from there. And after we did that trial process, we are now in a 10-year partnership with the government of Rwanda to integrate digital health into the, embed that in the healthcare system.
That's great, thank you. So that's a form of looking at kind of all integrated healthcare through a telemedicine platform and financing it. And Carol, I'd be interested in your perspective, because I think, as you know, that sometimes health services get siloed based on donors or different expectations, right? But we know that people aren't silos. They are looking for different health services at different times in their life. So Carol, based on what you see in Zambia, are there some good examples of integrated primary healthcare, or what would you recommend if there's not?
I would definitely recommend integrated healthcare. For TB and HIV, something that we've been trying for so many years, but what I noticed that it does work on paper, but in reality, it's a bit of a problem. Because if you're talking about achieving universal health coverage and then also reducing on the out-of-pocket expenses for most of the affected communities, it would be important to do that. Like I always say, you know, when a person is unwell, for example, just because I'm living with HIV, I have TB, I have COVID, you don't have to cut me into little pieces. That one piece goes to the COVID center, the other piece of me goes to the HIV center. You cut me into, I'm one whole person. You know, at the end of any illness, any service provision is a human being. So it's important to look at these numbers and that there's a person at the end, so that the people, the systems, you, the powers that we come together and just let me walk into one door, because I've only got enough money for that one day. I can only go away from my you know, market store for one day, or from my food for one day. Let me walk in, let me be able to take my baby for under 5, let me be able to do my COVID testing and everything. So really integrated service for me is something that will work right now. And you know, life is getting complicated. We are quarantining, there's social distancing. So when I have that one day to go, please take care of me as Carol, or a sick person, and not chipping and are not sharing me. Thank you.
It's so beautifully said. Exactly. Take care of Carol, and take care of each person as that whole person, and integrate services. So with that, we're nearly through with this really dynamic discussion. And I'd love to ask each of the panelists just for one sentence takeaway of what we need to do moving forward with primary healthcare to make sure it's meeting people's needs. So I'll start first with you, Carol, and then we'll move through to the other speakers. Thank you.
I think I want to re-emphasizing, involve the people who are directly involved, I mean, who are directly affected. Look at them as human beings and not just statistics. You'll be shocked at how they get things going. We got HIV medication quickly because people living with HIV got involved directly.
Excellent, thank you. Over to you, Salim. We'll skip Salim, he might be having difficulty getting off mute, and we'll go to you, Shivan.
Thank you. Sorry, can I go on?
Oh, no, sorry. Yes, go ahead, Salim, yes.
I think 2 things for me. One, that PHC now is the in thing. We should move or give it the urgency and importance that it serves. Secondly, I think we need to have people happiness centered in terms of having PHC owned by the people, and we have a resilient PHC. Thank you. Over.
Thank you. Over to you, Shivan.
Healthcare is an entire ecosystem. and partnerships is very critical. Resolving one element of primary healthcare without resolving the entire ecosystem will not be very fruitful. So what that requires is a lot of partnerships, a lot of collaboration between the different partners to provide the entire primary healthcare ecosystem for this one person. As Caroline said, how do you take care of this individual? You have to look at the entire ecosystem to be able to reform it to provide the results that you need.
Excellent, thank you. And over to you, Yeko.
Number one is to put health as a development agenda and more investment from governments on their health sector. And number two is, redefining the role of the private sector and non-government actors in health. And number three is adaptation of development assistance. All partners need to really adapt their assistance to governments to establish a resilient health system. Over to you.
Excellent, thank you. So through this panel, I think for me, my takeaways are we need to invest in primary healthcare. It is the core, it is essential for integrative health, but also for resilient systems in being at the front lines of current pandemics and future pandemics. And then it must be people-centered and engaged with the community. So with that, I want to give a wholehearted thank you to our stellar panelists, to Carol, to Salim, to Siobhan, and to Yeko, and to Nantalile, who set us off at the very beginning and framed our session. Thank you for your wisdom and thoughts about how we build back better with primary healthcare. So thank you and wishing you a good evening and day.